My plan is to talk a little bit about why myopia matters and why it's such a big deal at the moment, and also think about what those myopia management strategies are and how you can start implementing some of those with immediate effect.
The prediction for myopia prevalence in the future looks like something of the order of 50% by the time we get to 2050.
It's not just about the inconvenience of having to wear specs or contact lenses, it's about the eye health.
I want you to imagine that you're seeing this young girl and you might find that she is minus 0.50 right and left. Her prescription's going to progress. Her end destination is likely to be minus 6. If she stays at minus 6, then her risks for retinal detachment is 16 times that of an emmetrope. For myopic maculopathy, it's 40 times. If we can take our foot off the accelerator a bit and stop her hurtling down that road at 100 miles an hour and move it down to 50 miles an hour, her end destination is around about minus 3.25. Her risk factors do become significantly less. Now, if we take the foot off even more, by 75%, we end up halting her prescription at about a minus 1.25. Her risk factors become significantly more palatable at just 2 times. So this is why having control over any level of myopia can have a significant impact.
We don't really know why it's increasing in prevalence, but if we look at East Asia, there's huge problems in East Asia. 19 out of 20 people in some cities are myopic to a significant degree.
We're talking about large volumes of the global population having a myopic prescription, which will undoubtedly cause stress and strain and extra burden on any health system.
I hope in the Western world we won't have the same epidemic levels that we see in East Asia, but certainly if we look at some of the key studies from around about the 1980s, and compare those to studies now, we've definitely seen an increase in prevalence. If that continues, there could be a problem. And we don't want to get to that same sort of level as they have in certain parts of East Asia.
In terms of managing patients in practice, there are probably 3 steps to managing myopia. So the first would be to assess the risk, look at family history and assess refractive status. Also monitor how quickly that refractive status is changing. So even if a child is a plus prescription, if that's changing rapidly, that should raise a red flag towards a myopic prediction. In addition to that, we can look towards family history and recognise that parental history can often give us some clues as to what is going to happen to that child. We can also give advice on spending time outdoors.
There's recently been an analysis done, a meta-analysis of lots of papers, that's shown that UV exposure does actually correlate with the level of myopia. And the more UV exposure you have as a marker of being outside actually limits your myopic progression. So if a child is outdoors playing lots of sport, they'll have a lower risk of being myopic than someone that's spending less time out of doors. So that could be a real factor in myopia control, just changing your lifestyle, a more healthier lifestyle, go outside, play sports, and you'll be less myopic.
What's really exciting is being able to offer an intervention to help halt or reduce the progression of myopia with optical treatments, and those can range from spectacles, which can sometimes give moderate reduction in progression, through to contact lenses, which can really make a difference to the way that child progresses.
If we were able to control myopia by 50%, that would lead to a reduction in the frequency of people with prescriptions over -5 of 90%. So that's a big deal.
A great thing that a practitioner can do is make sure they're really up to date with the research in these areas. We've got in certain areas of the world myopia control lenses that are being used. They will hopefully be rolled out in the UK.
Am I placing a child at risk of infection by putting them into contact lenses? Well, the answer is yes. But are you also putting that child at risk of myopia-associated pathology if you don't do anything about it? And the answer is yes. So what's the difference? Where do we stand? Well, the lifetime risk of MK with a daily disposable soft contact lens is something of the order of 1 in 75, and that's over decades of lens wear. And the lifetime risk of retinal detachment for a patient that has -5 or more is something in the order of 1 in 20. So it's 3 times more risky to do nothing than to do something.
They can really get involved in myopia control and also get involved in the research that underpins that. What we need now is lots of evidence to show that myopia control strategies are working, are showing promise, and influencing policymakers so we can roll those processes out, and they're properly funded by the people that control where money goes in health services.
I see myopia management as a very exciting opportunity for optometrists. This gives us a real chance to actually treat a condition within the space of our own consulting rooms. Something that we've not really had access to before. We've certainly been able to correct vision, we've been able to recognise pathology and perhaps refer that on. But with myopia management, it does give us the opportunity to really have a look at being able to intervene from the confines of our own consulting room.
One thing I would say is if you get a knockback when you're discussing this, always persevere. The public are really uninformed, and it's not their fault, but they are uninformed about myopia control and what we can do in practice about it. And it might feel a bit strange to them at first, and we don't like being rejected. We don't like having the word no said to us. But it's really important that we continue to persevere with these parents because the outcomes could be significant for everybody involved.